All right. So tonight's session is about TMJ do's and don'ts. And sorry for my little cat here, so I got to get her out of the way. But so a lot of times people will treat the TMJ and not exactly know what they're trying to treat, but that somebody has a TMJ problem. As we're going through this, by the way, if anybody has any questions, just post them in the chat or the Q&A, and we'll try to pause if we can. We'll definitely set aside some time at the end to answer all of your questions, but feel free to post them along the way. And if we need to pause and kind of clear some stuff up, I'll be happy to. All right. So right off the bat, I just want to talk about the fact that we tend to treat two different patient populations in our office. We treat patients who things are working for them, and we treat patients who things are not working for them. The general patients are the ones that we get to do some routine general dentistry, no issues whatsoever. And then we've got a whole bunch of patients that things aren't working. The size and contour of their teeth, the position of their teeth are not appropriate, and it can set us off with some issues for some TMJ problems. In general, the buckets of types of patients that we have our traditional bacterial-focused patients with decay or periodontal issues or endodontic issues. We've got our functional-based patients who have some tooth wear, migration, muscle issues, and TMJ issues. And then some patients that are focused on some aesthetic issues as well. And we've got a fourth bucket that we've been talking about for quite a while, and that's airway based or airway focused issues, which unfortunately or fortunately is a driving factor for everything else a lot of the time. So we have to make sure we're mindful of the airway. We're looking at people's airways and how that might play into everything else. So I'm just going to put a question out there for everybody, and you can feel free to put it in the chat. But in general, what type of splints are you currently using? I like to use the word splint as opposed to any other type of appliance because there's a purpose in general for the pieces of plastic that we might prescribe to somebody. But in general, if you don't mind putting some in there so that we can discuss, all the different styles of appliances that are out there, which we will be going into in a second. But I want to change the word of what type of splints we're using to what type of splints we're prescribing. Because splints in general, there's a purpose for them. A lot of people that I come across, or a lot of patients that I come across, have been given a splint to use, and very often it is what everybody tends to call a night guard. A night guard is a piece of plastic that you put between your teeth and protects you from bruxism. So there's nothing that's really prescribed aside from where you don't want the teeth to hit against each other. So we hit against a piece of plastic. A lot of the patients that I see in my office are patients who were prescribed or were given a night guard to use that's not the right type of orthotic for a patient. And lots of times they'll come in with more discomfort. So I want to go a little bit tonight into the different types of splints. And one thing right off the bat, I said that this was about TMJ do's and don'ts. One of the don't that I will strongly caution people to do is to prescribe a night guard. Because a night guard or a piece of plastic that sits between the teeth can cause a lot more damage than the benefits that arise from it. So there's tons of different types of splints that are out there. We'll go into some detail here. We have our classic splints that cover one arch. We have splints that cover part of an arch. We have splints that cover both arches. So we're going to a little bit of detail as to the different styles of splints that are out there. But in general, if you prescribe a splint that is meant to manage the TMJ, we also want to be aware that the occlusal scheme that a patient has it can also be contributory. It's not the contributing factor for every single TMJ issue that's out there, but there is absolutely no harm in perfecting an occlusion. And once again, I know that the literature out there is questionable as to, how high a percentage we can place on occlusal forces, but we do know that occlusal forces, if they're idealized, do not cause any damage. So want to be clear about that right off the bat. But when we use a splint, we want to monitor it. We want to see what effect did it have overall. Did it have a positive effect? Did it have a negative effect? There are some splints that I've used that the feedback that I get, if a patient's worse, that's also information that I can use to try to figure out what condition they might have or what course we might need to correct. Um, a very, very quick, easy differential diagnosis for what type of splint we might want to prescribe if we're going to prescribe a splint for a TMJ condition is an anterior deprogrammer. The simplest anterior deprogrammer that's out there is one that Dr. Dawson used many times for many years, and that's cotton rolls. Cotton rolls that sit from the canine forward disocclude the back teeth, and they can act to turn off muscles, and they basically shut off muscle activity and can seat the joint. So something as simple as a cotton roll can help us with the differential diagnosis. We have quick splints, aqualizers, lusojigs, NTIs. There are so many different versions of anterior stop appliances, and we'll go into a little bit of detail of those in a second. But what they all do is in this bite effects example right here, you'll see that the splint is an NTI style splint or a sectional anterior deprogrammer or a lucia-jig, and it basically clears the dance floor. It basically makes it so that the muscles get a feedback to the brain that says, I've got no food to chew. We can shut off and we can see the joint in a relaxed position. So any type of splint that makes it so that the back teeth don't hit can effectively do this same sort of function. It can shut off muscle activity, seat the condyle in the fossa, and shut off muscle activity. So there's, once again, many, many different types. A nice, quick, simple one that I use in my office for emergency urgent care visits is a quick splint. A quick splint is a piece of plastic that covers pretty much from your canine to your canine, and you reline it with a little PVS bite registration material. They actually now have it in a putty material instead of an injectable. And you seat it over the teeth, and you gently bite into it, trim off the excess, and all of a sudden you have a nice little appliance that you can make in about 2 minutes that can act as a differential diagnosis or can actually start some sort of therapy. Once again, it's going to be a situation where none of the back teeth hit, only the canines and forward, and it shuts off muscle activity. One thing I do want to mention very, very strongly, I see patients that come into my office that have been prescribed some sort of anterior stop appliance that does not, or actually not just an anterior stop appliance, any appliance that does not cover all of the teeth. You have to be very, very cautious because if you are making somebody better with whatever type of splint you might be prescribing, if it does not cover all of the occlusal surfaces of at least one arch, there's a high tendency for teeth to migrate. And when patients are feeling better with an appliance, say, I'm just going to use an example of an NTI, which is a very, very commonly prescribed one. If you use it for too long and don't have at least 30 to 40 incidental contacts of the teeth over the course of the day, you actually can have irreversible changes to the occlusion. So you want to be very, very cautious in any segmental appliance because you'll have a very, very high chance of adverse effects in the occlusal scheme. And now you have a patient who might have been better from the orthotic that you prescribed, but because of indiscriminate or overusage of the orthotic, we now have a situation where we have a large occlusal scheme that, or a very poor occlusal scheme that has developed and now has to be managed. But ultimately, what we want to do is we want to have a differential diagnosis of the level of dysfunction of our TMJ condition, and then prescribe a splint appropriately if a splint's even indicated. Tons of patients that come into my office are told or feel that they have a TMJ problem, and a lot of them actually don't have anything that's structurally incorrect about the TMJ. So that's one of the clear messages I want to leave everybody with today, is that there is a differential diagnosis. We can come up with a differential diagnosis in a matter of minutes and determine what level of breakdown we have, so we can figure out what course of action do we need to take. So without mentioning the different stages of the TMJ breakdown, I don't think, sorry, it's my cat again. I don't think we can go a whole lot further. So let's talk about the different stages of breakdown and what's intact and what's possibly not intact. Right. I like to use a Piper classification. I'll use other terminology that can describe the type of breakdown as well, just so that we can use a universal nomenclature. But the Piper classification, stage 1 joint is a joint that is a healthy condyle disc assembly. Basically, there's no breakdown. The ligaments are intact. There's no ligament laxicity. The joint's loadable. The articular disc is centered nicely over the condylar head. There's able to be proper rotation, proper translation with no structural defects whatsoever. So that's a Piper stage 1, or a fully healthy condyle disc assembly. Stage 2 is where we start having some ligament laxicity. The lateral pull of the articular disc is starting to snap on and off of the condyle, but it might not be happening all the time yet. So this is a situation where you might have somebody who wakes up in the morning and they might have been parafunctioning all night for multiple reasons. They wake up in the morning, they have to jiggle their jaw around a little bit, and it pops. And then they're able to go the rest of the day without any issues. So this is something that happens maybe once a day, once in a while. It's an early breakdown of the condyle disc assembly. It is sometimes something that alarms patients, because at this point it can be a loud snapping click, and we'll get to that in a second. I don't mind loud clicks. Loud clicks are actually good in my world. Stage 3A is where it becomes a reciprocal click that's reducing every time you open and close. So this is a situation where the condyle is going into rotation and there's no sounds whatsoever. You start going into translation, and probably at around 20 to 25, maybe up to 30, 35 millimeters of opening, you hear a loud snap. Once again, this is early in its breakdown relatively. There's probably about estimated somewhere between 60 to 90 million Americans walking around with breakdown of this sort of level. This is a situation where the condyle has condyle disc assembly has distorted significantly, but when you look at the anatomy overall, it's only broken down about half as far as it can break down. So when we look at the condylar head, we have an articular disc that's sitting on top of it, kind of like a basket handle. And this is the lateral pole, or the outside aspect, that is popping on and off. And it's out of place initially as the condyle is sitting in the fossa. And as it rotates and it starts translating somewhere along the eminence, it pops back into place. And once again, early on, before the ligaments get too lax, this is a very, very loud snapping click. This is the one that a lot of times people will come in and say, oh yeah, it's making a lot of sound when I eat. Somebody in the family will say, hey, you know, that's bothering me more than it's bothering you. And you got to go see somebody about it. It's not a situation that's necessarily always causing pain at this stage. It can cause headaches. It can cause some discomfort in the joint, but it doesn't necessarily. Because when you look at the anatomy, we have the basket handles popping on and off on the outside at this point, but there's still the inside aspect that's fully intact. So we'll get a little bit more into the anatomy in a second, but this is, for me, if I get patients at this level, they're relatively easy to treat. I definitely do not feel the need very often to put somebody into long-term splint therapy at this level. I can actually, more often than not, when the ligaments haven't gotten too lax and when it's that loud snapping click, I usually can come up with a situation of trying to figure out how can I alter the occlusal scheme to make the continual breakdown of the TMJ far less than it's been. As time goes on, the ligaments start getting a little bit lax, and that loud snapping click starts getting a little bit dull. When I discuss this with patients, I kind of tell them it's been like you have a rubber band and you keep on snapping that rubber band back and forth over and over and over again over time. And then eventually that rubber band doesn't go back to its initial form because this disc has been, the articular disc has been slipping on and off on the lateral pole for a while. Ligaments are getting a little bit lax and they're not recapturing quite as much as they were before. So this is a situation, if you talk to a patient, they might say, well, yeah, I used to have a click for a long time and it was really, really loud. And then it just kind of started going away. If nobody got in there and prescribed any sort of occlusal therapy or prescribed any sort of orthotic therapy, the situation didn't usually get better. More often than not, the situation got worse. So this is once again a disc on the lateral pole that had been snapping on and off as you go into translation. And now, as you go into translation, it's still out of place. So it had been popping back in as you went into translation. Now the lateral aspect is still out of place. So this is becoming, at this point, it was a reducing anterior disc displacement on the lateral pole up to now. Now it's a non-reducing lateral pole displacement. But once again, the medial aspect of the articular disc is still intact. So up to here, usually this is not necessarily long-term splint therapy for somebody. This is usually somebody I can get into treatment pretty quickly to figure out, what alterations can we make to improve the occlusal scheme. As time goes on, and if nobody gets any treatment, no orthotics or no occlusal therapy, the medial aspect of the articular disc can start popping on and off. So I keep on going to my hands here. I hope you can see them well. But basically, the lateral pole at this point is off. It has no longer recapturing. And then the medial aspect is starting to pop on and off. So in rotation, when the condyle is seated in the fossa, lateral pole has already been off now at this stage. The medial pole is off as well. You rotate a little bit, maybe about 10 to 15 millimeters, and all of a sudden you get a little pop back on. So this is a reducing click of the medial aspect. So the lateral pole or the lateral aspect of the articular disc is completely out of place, completely displaced. The medial aspect is starting to pop on and off. Up to here, you still at least at times have articular disc sets in place on the working end of the condylar head where the condyle is in the fossa in its most superior point. But when the condyle gets fully all the way in the fossa, you have a disc that is out of place. So when the condyle starts, so when you rotate a little, it pops back into place. But when it's fully seated, it's out of place. So the retrodiscal tissues that support and supply the joint with its neurovascular bundle is starting to come into the joint space. The disc itself is an avascular disc. It is not innervated in and of itself, but there is a big retrodiscal tissue that supplies the joint from behind that when the disc is displaced can start entering the joint space. And so left alone as time goes on, the disc on the medial aspect can be off. So that the lateral aspect has been completely off for a while. The medial aspect was popping on and off in rotation in that first 10 millimeters of opening. And now it's popped completely off on the medial aspect. So this is a situation that it had been popping on and off for a while, it was recapturing, and now it's no longer recapturing on the medial aspect. So if you can think about the anatomy for a second, this neurovascular bundle that was supporting and nourishing the joint space is now coming into the joint space. And every time the condyle goes into the fossa, you're pinching on that retrodiscal tissue and you're pinching on the neurovascular bundle. So the disc is completely out of place, and this is a situation where you have a fully displaced disc without reduction. So this is an anterior disc displacement on the lateral and the medial aspect without reduction. So this is a fully displaced disc. All right, so as time goes on, the condyle gets further into the fossa and it starts pinching on the retrodiscal tissues. This is usually at this point from stage 4A to 4B into 5A, we usually have a pain patient, a very extremely uncomfortably painful patient. So this is the situation that they get no relief. So the condyle is not protected by the disc. It is pinching on those retrodiscal tissues, and they start feeling quite a bit of pain. So this is the active pain patient. A patient that is in this medial pole breakdown, so from stage 4A and beyond, is a patient that should be you should be very cautious of doing any treatments, any long treatments on a patient. Emergency care is still always needed, abscess, things that have to get taken care of so that there's no health-related issues need to be addressed. But this is not a patient who we'd like to have in the chair wide open for a while. This is a patient, if they're in stage 4A and beyond, if they're sitting to get wisdom teeth out, they may never really recover. They might fully be pinching on those retrodiscal tissues and have pain that does not go away for quite a long time. So this is also a type of patient that we don't want to do a long root canal procedure. We don't want to have them in the office or in the chair for a quadrant of dentistry. This is a kind of a moving target at this point. So this is a situation where the joint should be addressed as opposed to doing other treatment aside from emergency care or urgent care that really does need to be addressed, but in the simplest, shortest amount of time that is possible. Right? As time goes on, the retrodiscal tissue gets perforated through, and the condyle is fully in the fossa with no articular disc, no retrodiscal tissues, nothing at all that is protecting the condyle from the fossa. And so you're in a bone-on-bone situation. As time goes on, a bone-on-bone situation, just like any other joint in the body, can remodel and can be adapted. So if and when we get to this situation, this is a sort of situation where the occlusal scheme of the patient might alter as time goes on, and it actually will alter as time goes on. But this is a situation where you can get some stability again. It's that stage 4 where you're really a really moving target and have to really watch to try to figure out if you have a patient in that stage. We want to really watch what sort of dentistry we do for them. So we had already mentioned this, that the retrodiscal tissues, every time the disc is displaced or every time the condyle comes down the fossa or down the eminence, the retrodiscal tissues come into the joint space. So when the disc is completely displaced, the retrodiscal tissues are in the joint space all the time. So one of the other things that we do to kind of help us in our differential diagnosis, one thing we mentioned before was an anterior deprogrammer, something that just gets the back teeth out of the way, it turns off those muscles, seats the condyle and the fossa. Another thing we can do is bimanual guidance or bilateral manipulation, where we put a little bit of pressure on the condyle and the fossa. There's a very special technique for this. Those of you who have not been in classes with us, we'd be very happy to teach you the technique. But basically, it's a rotational technique where we're putting a little pressure on the chin and seating the condyle and the fossa orthopedically to determine if it can accept loading. If you have displaced discs on the medial aspect, you'll be pinching on retrodiscal tissues as a condyle seats in the fossa. So a level 1 of incremental load, where a couple of 1 to 2 pounds of pressure on in the fossa could elicit discomfort, and it would be tension or tenderness that we ask if the patient feels. If it's tension, it's a little bit more of a muscle sort of situation. If it's tenderness, it could actually be pinching on the retrodiscal tissues. So an anterior deprogrammer like a cotton roll or a Lucia jig or an NTI, if somebody feels worse when you do that, when you put one of those appliances in and seat the condyle into the fossa, if they say after about a minute to 2 minutes or a little bit longer, it's like, I didn't feel so bad at the beginning, but I actually feel a sharp shooting pain over here. That is a sign that we have acute displacements of the articular disc. So we want to be very cautious as to how we proceed. So going into the different types of splints again, the anterior deprogrammers are a permissive splint. The sectional type is, as we mentioned, the Lucia jig or the NTI or things similar to that. A dual arch B splint is a full coverage splint. I'll show you a picture of in a second that covers all of the teeth, but still has an anterior stop. It has a situation where the back teeth are still out of the way, but all the teeth are covered on their occlusal surfaces so that no teeth can super-erupt. Then we have our classic splint, and this can be an upper or lower splint, a superior repositioning splint, one that has a perfected occlusion that's designed on it, and it allows the condyle to seat into the fossa. We also have, and that can be an upper or lower. It can be a Michigan style or a Tanner style is on the lower, Michigan style is on the upper, and there's numerous other types, but they all serve the purpose of trying to perfect an occlusal scheme on the splint so that basically we can get some readaptation and remodeling of the articular surfaces or of the joint space. Then we have directive splints. These are two major classifications. One is an anterior repositioning splint. This is very seldomly used. It might be used in an acute disc displacement, somebody who had that snap, it actually popped forward and they're really, really uncomfortable and they're locked. They can't open too much. We might put them into an anterior repositioning splint for like a week or two to kind of maybe recapture or kind of not unload, but get the pressure off of from the condyle in the fossa to allow a little bit of inflammation to decrease and have that joint heal just for a little bit before we go into a superior repositioning style splint. Amara appliance is another another directive splint. These splints put people in a certain position. Amara appliance is a mandibular anterior repositioning appliance. The most common types that you might have heard out there are pretty much any one of our sleep or snore appliances. They all hold the condyle down and forward in an end-on or a further forward position that keeps the condyle from seating into the fossa. That's not the purpose of those appliances, but that is what they do. They pull the condyle down the eminence, and the condyle is not seated in the fossa. So these are our typical types of anterior deprogrammers that we can use. This is an NTI or a Lucia jig. They turn off the muscles. We want to use a sectional type for a very, very short amount of time. We sometimes use it for diagnosis. We'll sometimes use it to take a bite record, but we do not want a patient wearing this for long periods of time. As we said earlier, we don't want any occlusal changes to occur, which is very likely if you have a sectional or an appliance that does not cover all of the occlusal surfaces. A dual arch B splint, if you need to have a patient in a muscle-directed appliance for longer term, a dual arch B splint is basically two Essex retainers with a little acrylic ramp in the front that does not allow the Essex retainers to come together. They're made a little bit more durable than just Essex now. They're a little bit stronger. But the ultimate effect is that they do this clearing of the dance floor. They basically are able to seat the condyle in the fossa, and none of the posterior teeth can hit. Some people do like to use them for headache patients. Longer term usage is absolutely fine in an appliance like this because it's covering all the occlusal surfaces. So if you need to protect somebody from a clenching and grinding habit, there's nothing wrong with this type of splint. But once again, with all of these anterior deprogrammer type splints, if somebody complains of a sharp shooting pain in the joint ever, they need to discontinue use. That means that the joint situation has gotten worse and we're starting to pinch on those retrodiscal tissues. This is a classic splint that we have used for many, 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 many years. I tend to make an upper, a lower is fine as well. Change depending on the occlusal scheme that a patient already presents with. But if I prescribe a superior repositioning splint, I'm prescribing it when I suspect a Piper stage 3B or beyond. So this is not a loud snap and click. This is where disc is already partially displaced or not recapturing. At that point, the retrodiscal tissue is coming into the joint space, and I don't want to put any more pressure on the joint until I have had a chance to manage it. So this is something that we basically take our bite records, take our impressions, and have a lab fabricate an occlusal scheme where we have a perfected occlusion with a very shallow anterior guidance. So when you bite down, you hit evenly all the way around the splint, and when you slide around in any motion, the anterior aspect of the splint discludes the posterior. So when you clench down really, really hard, you can actually still feel all of the surfaces of the posterior and the anterior all hitting coincidentally. And when you slide in any mandibular motion, the anterior aspect is discluding the posterior. So I want to keep that ramp as shallow as possible. This sort of situation is a type of patient or a type of overall joint classification. I'm going to bring a patient in for sequential adjustments. So on day one of delivery, I'm not going to try to load the joint. This is a patient with a bad joint. I'm going to bring him back in a couple of weeks, check the joint, and slowly every 2 to 4 weeks, adjust that splint so I can load the condyle in the fossa and be able to eventually get a firm orthopedic load with the condyle in the fossa. So this sometimes takes some time. This is usually a situation where we're in orthotic therapy for no less than 3 to 6 months, and sometimes it's 6 to 12. Whenever I start this on a patient, I let them know I can't dictate the time of treatment. Your body is going to dictate the time of treatment. So I've got some patients, it took almost 2 years to get the joint healthy again. I've got some patients, it literally only took 3 to 4 months. So a direct to splint, once again, I don't use that often, but I have used one in an acute displacement a handful of times. And it, once again, just allows the condyle not to seat in the fossa at all, and allows a little bit of healing to go on so that we can then prescribe an SRS or a superior repositioning type splint. The other type of directive splint, the MARA appliances are very, very commonly used. I know a lot of people are prescribing them when people are CPAP intolerant for OSA. And the problem is that when the condyle is down the eminence all the time, the retrodiscal tissues are sitting in the articular space, and they sometimes can permanently lodge there. And then you can have patients come in with posterior open bites. There's rampant changes that can happen, and then the condyle disc assembly ends up being permanently altered. So anytime you have a patient in a directive splint like this, ultimately we have to get the condyle into the fossa to get into their habitually joint seated position. So if you do prescribe any OSA appliances of any sort or snore appliances, the AM aligner is very, very critical so that the joint can go back to its normal anatomy. Otherwise, once again, you can have a very, very permanent maladaptation of the joint. So the anterior deprogrammer can help in our diagnosis. If you wear an anterior deprogrammer and you get worse, then we suspect an intercapsular problem. If you wear an anterior deprogrammer and you get better, we suspect more of a parafunctional situation or an occlusal muscle problem. If you get worse on loading or an anterior deprogrammer, we suspect once again an intracapsular problem. We're going to go to long-term splint usage to help adapt those TMJs. All right. I'm going to just show you the different types in the categories again. So an extracapsular problem, we can use any sort of sectional anterior deprogrammer. Once again, be very sparing or be careful of use of a sectional style, but the anterior deprogrammers will turn off the muscle activity, seat the condyles in the fossa, and protect from parafunction. The intracapsular problems, I would strongly recommend an upper or a lower full arch splint that initially is going to be maybe close to their MI or maximum intercuspation position that we can sequentially adjust and basically walk the patient back into a joint seated situation. And then occasionally we might use something that doesn't allow the condyle to seat at all if we need to for a very short period of time. So we have to make sure we know the diagnosis of what type of patient we have. And if we have an occlusal muscle situation, we can go ahead and start treating the occlusion pretty quickly. If we have an intercapsular situation, we have to work with a splint for a while and make sure that there's no changes on the splint for at least 3 months before we proceed to try to correct any sort of a occlusal uh, occlusal scheme. Now, the unfortunate part of somebody who has any sort of displacements, it will not go back to normal necessarily. Once in a while, you can recapture a disc, but it is just not as stable as it was before. So this is a situation where I'm very clear with the patient that we're going to manage your joint breakdown and we're going to try to minimize the rate at which it breaks down for the rest of your life. If we perfect an occlusal scheme and then eventually perfect an occlusion, we will break down as slow as possible. Right? And then once we've done any sort of splint therapy, we'll get some new model analysis, new mounted models to figure out, what are permanent solutions so that we do not have to rely on a splint all the time. We're always going to be looking for signs of instability. We'll look in the beginning, but when we're treating a TMJ, we're concerned with that more, but we're still looking at what other situations a patient has. So we're going to look at a whole bunch of signs of instability and signs of stability and see what the patient presents with. Do they have a reasonably even occlusion? Do they have teeth that are in the right place? Do they have stable TMJs? Do they have worn dentition or not? We're going to look at all these things as part of our exam process to then figure out once we're finished with the splint therapy of whatever sort we might do, what are our next options? Ultimately, we're going to look at a patient from a comprehensive manner, and we're going to see, do we have to treat the joint first? And if we do, we treat the joint, and then we go ahead and we treat the occlusion. Whatever I come up with for a patient, I'm always trying to do the least amount of dentistry possible, but I'm not trying to do no dentistry. I don't prescribe a splint indefinitely for a person. It is a purposeful act. We are trying to treat something, and then once we've treated that, we go ahead and we try to figure out what are our options to actually treat the dentition. So let's meet Dana. Dana presents to me on a referral from another general dentist in the area, a friend of mine who does not like to treat TMJ disorders. She's been in the practice for a while. She's had some basic dentistry done, some fillings. They tend to pop off, but Dana one day came into the office and was not able to sit for a hygiene visit because she was in so much discomfort. Turns out that she was pregnant also at the time, so there's a lot of maybe hormonal changes that are going on that are affecting the joint, and her occlusion has been slowly destabilizing for a while, and it just came to a head, happened to be at that time. She noticed it when actually she wasn't pregnant, she just had delivered a baby, so she was actually feeding when she first noticed her first discomfort apparently. So that's how Dana comes into me. And so I go ahead and I look around to see if there was anything urgent. Luckily, she was already being treated by a general dentist who said she was cleared. I looked at all the existing restorations. Nothing needed critically to be addressed. So we were able to treat her joints. And she had a red joint. So when I did bimanual manipulation, her joint was very, very uncomfortable. She was load positive on level 1 of incremental load. And when we put a little deprogrammer in for a couple of minutes, she also felt a sharp shooting pain. So when we look at our differential diagnosis between that, and I also use a Doppler ultrasound to listen to the joint. and I heard a lot of crepitus and a lateral pole click that was barely recapturing only once in a while. So Dana ended up having a stage um, 3B situation. So it was displaced and it was kind of clicking on and off, but on top of it, she was starting to have a little bit of a displacement on the medial aspect. So she came to me when when the clicking was already starting to go away, and that's when she presented. So ultimately, she had no loadable joints. So what we did, we put her into a full arch orthotic. It took somewhere between 6 to 12 months of precision splint therapy to get her to have a loadable joint so that we had no changes on a splint for an extended period of time of at least 3 or 4 months. And I was able to put firm pressure on her with her condyle and the fossa with bimanual manipulation. So we did not recapture the disc. What we ended up doing was we got a pseudo disc formation, but we got a loadable joint finally. So this took us, as I said, somewhere between 6 to 12 months. Dana, from not the first visit, probably the second visit of adjusting the splint, finally got her first relief in a very, very, very long period of time. So that's the type of splint I use, very, very classic occlusal scheme that we sequentially adjusted and were able to seat the condyle as superior as we could in the fossa. All right. Then after she was all done with splint therapy and we deemed her condyle or her condyle disc assembly as healthy as we could get it, we then came up with a plan. We put her into our records process and said, all right, the way I approached the patient was basically what we want to do is we don't want to have to rely on this splint all the time, because when we go through active splint therapy, it's 24/7 use because we are creating a substitute for a perfected occlusal scheme that is able to start healing and seating those condyles in the fossa. So she also was definitely interested in the idea of not having to wear the splint all the time. So we came up with a plan when we did our model analysis, our mounted model analysis. We determined that her occlusal scheme was inappropriate, and we developed a plan to expand her back teeth, get her front teeth coupled a little bit. We spent about maybe 9 to 12 months in Invisalign, getting her arches nice and rounded out. And then we did some very, very conservative composite bonding to replace where she had worn out some of her cuss tips. And then we did an equilibration. So basically, this was an additive reductive equilibration that basically created a situation that our own teeth coming together acted just as what happened when she was biting on the splint, when she was closing on the splint. So this is how Dana ended up. So very, very conservative on the dentistry side, a handful of fillings, maybe more than a handful. I think it was about 12 fillings and an equilibration. And she was very, very, very stable. So what we did at the end to protect her after after we did that, we did make our nighttime splint, and we did explain to Dana that this will most likely need to be touched up every few years because your joint has been altered. And even though we spent the 6 to 12 months on orthotic therapy and got loadable joints, and we spent the time on Invisalign and then an additive reductive equilibration to reproduce that idealized occlusal scheme, when you have an altered condyle disc assembly, there's no guarantee that it's going to stay perfect long term. So Dana fully understands that every so often we might need to do a little touch up of her equilibration to maintain the health that we achieved. Right. So in the end, we had a happy patient, a healthy patient, and one that took us some time, but has been stable now for many, many years. So that's the end of the kind of the clinical part of tonight. But I would love to open up the the webinar to anybody with any questions. I just want to show a couple of slides here in the background as we are doing that. If you want more knowledge, all these classes will definitely help. On that note, I want to say thank you guys.